Welcome to the SAGES 2020 Nightmare on Colorectal Surgery Street session. I'm Joe Guy Vituri from Dartmouth, New Hampshire, where we'll be doing two case presentations. The first one is a Re-Operative colorectal surgery case presentation that we will go through. I have no disclosures. It all started with diarrhea and a colonoscopy. 44-year-old female with a 1-month history of abdominal pain and diarrhea. She had a CT scan that's shown to the right that showed proctosigmoiditis. The initial colonoscopy showed severe ulcerations from rectum to descending colon. This was done about a week after the CAT scan, but the colonoscopy was aborted somewhere in the descending colon due to patient discomfort. Unfortunately, about 6 hours later, she presented with severe abdominal pain, peritonitis, free air on chest x-ray. Oh man, peritonitis, open abdomen, prolonged hospitalization. This was all done at one of our regional hospitals. Patient was taken to the OR and had multifocal perforation of the colon, the cecum, transverse colon, descending colon. Patient underwent a total colectomy, open abdomen, and the colectomy path ultimately showed indeterminate colitis, no granulomas. They favored Crohn's due to transmural inflammation, but in the setting of acute perforation, it was very hard to determine whether this was just related to severe colitis. The abdomen was left open and had multiple washouts, about 7 washouts. Also ultimately was transferred to our center where her abdomen was closed, and they were able to finally pull up an ileostomy, although it was flush with the skin. And they noted a frozen abdomen on the last operation. The hospitalization was severely complicated by E. coli bacteremia, bilateral septic hip joints due to the E. coli bacteremia, resulting in avascular necrosis of the right femoral head, antibiotic spacer placement. She had a chronic infection on the right hip joint as well as the left hip joint, and recovered very prolonged recovery, was in the hospital for about 4 months. Now let's fast forward to 1 year from the inciting event. She now has a rectal stump fistula to the abdominal wall. She has critical illness myositis. She's wheelchair bound, not able to walk, non-bearing on both legs with bilateral chronic septic hips. She has an MRE that shows no small bowel disease, and the MR pelvis that shows those hip joint infections. And this is an example of the rectal stump fistula. You can see the staple line on the left image, and it fistulizes to the top of her incision. So the rectal stump fistula is around the area of our very low hypogastrium, but the actual fistula on the skin is on the upper aspect of her abdomen. So very complex fistula that she has. So here we are. We need your help. Patient's got reasonable nutrition. She's got bilateral septic hip joints. She's wheelchair bound. The MRI and MRE show no active small bowel disease, and endoscopy confirms this. She has a flush ileostomy. She has a healed midline incision, but she has that rectal stump cutaneous fistula on the top of her wound. Oh, by the way, she now has some vaginal drainage that looks similar to her fistula drainage. And our orthopedic surgeon says, I can't fix her joints until her fistula is fixed because I'm really worried about getting another infection and really infecting the new hardware that I put in. So she sees you in the office and she has 3 questions for you. She does, number 1, can I have my ileostomy reversed? So I'll put it out to I'm happy to answer any questions. This was her question to me. Can I have my ileostomy reversed? She has an end ileostomy. She has her entire rectum. She has probably another 10 centimeters proximal to that, with that fistulized to the abdominal wall in a complex manner. There's no small bowel involvement. There's no enteric content drainage from the fistula site. There is some vaginal drainage. And she wants to know if she can have her ileostomy reversed. This question of indeterminate colitis. So I'll ask the group for some help.
I'm happy to start. I'm always kind of a loudmouth. It's pretty easy to find out what's going on with the vagina. between MRIs and contrast studies, so you can kind of rule that out or rule it in as an ongoing problem with the rectum. She's wheelchair bound, so you give her a pouch, she's going to be unable to rush to the bathroom. So functionally, even if you could do it from a technical perspective, that's not a good idea. And you have this question of if this rectum is diseased or healthy. Is it really just diversion proctitis? So I mean, in her current condition, I would never take her ileostomy down. Instead, I would try to get her a well-functioning ileostomy if it could be revised locally. If it's truly a problem with pouching, you said it was flush with the skin.
Mm-hmm.
Try to get her, hips fixed or get her to whatever her ceiling is on recovery, and then maybe revisit it. I do think, just since we're talking about this fistula, I mean, a fistula colorectal stump, you know what I mean? Like, that's basically a mucus fistula to me. It's hard to get too excited about that. Some people do that on purpose. In the same case, they would have brought that up to the skin on purpose. And so I don't know why she would be getting septic from that, or why, if that's widely and well drained on the skin, I can't imagine that would be preventative to a reasonable orthopedic. Maybe just needs to have a conversation about what this fistula means. So that's kind of my 2 cents about it. But.
So that's a great point, and a discussion with the orthopedic surgeon. They're just, they have dealt with this for over a year with multiple aspirations, prolonged antibiotics, infectious disease consultations. They don't want to take any chances with these hips.
Sure. Saying
the same thing. No, that's an excellent point. So what I'm hearing is you would consider doing maybe an exploratory laparotomy, giving her a better ileostomy, maybe fixing this fistula without actually going deeper, or we try to locally repair this?
Yeah, I mean, like frozen abdomen is very subjective. It doesn't intimidate me necessarily, but and I think that if she truly was having a fistula that was poorly controlled, one could consider that. If that was truly causing ongoing infection that couldn't be controlled. But if that could be controlled local wound care, I would do a local revision on the ileostomy rather than go back into her abdomen. But that's just because you mentioned that it was flush.
Yeah, it is flush, and she had a lot of severe skin irritation.
Yeah, that's what I would recommend as a start.
I have a question on physical exam on scope of the rectum. Is there communication to the vagina?
It's hard to tell, but there does not appear to be any output from the vagina when you scope in the rectum. There's no gas that comes out. There's
so this is just a subjective complaint, but it hasn't objectively been identified.
Correct.
What about seen
on MRI?
I recognize that that's her first question, and I think the answer is probably eventually it's possible. What about endoscopically clipping the mucus fistula?
It's quite large. It's actually so it's this. I mean, so you would consider endoscopically clipping. This is the area that they see where they see some staples. They don't know whether this particularly is the actual fistula itself. We're presuming that it is, but you would consider endoscopically clipping it.
Yeah.
As an option. Okay.
Yeah. It can't hurt.
It can't hurt. Okay.
And how does the rectum look? Just diversion proctitis? No.
Just diversion proctitis.
But on the original colonoscopy, when she was very ill, it was from the dentate line up.
From the dentate line up.
Yeah.
From the dentate line up with severe inflammation.
I would also just mention that with the clipping, I think it's a great idea. I've had bad luck, and the reason, so a little endoscopic clip won't work, so they use like the Ovesco or the bear claw clip, and sometimes you have a little hole, and then they clip that thing, and it becomes ischemic, and when you go back and look again, it's big hole. And so I haven't had the luck that I wanted trying to go in and clip these fistulas, but I actually think it's a great idea, especially since the size of the hole is not a problem here.
And not just that, it's a really long tract. The external component to it is far away. So I think that, a little bit of debriding of the tract in a clip has a chance of working. I've had some success with it, not maybe 50-50, but I've had some people who've healed. As a bridge.
As a bridge. with the hope that if you clip it and the fistula kind of is more quiescent, that they could then do their orthopedic procedures.
Yeah, because if her ultimate goal is ileostomy reversed or, J pouch, that kind of stuff, then having her be a mobile person should be part of the criteria for that.
Any other thoughts?
So I am the eternal optimist, but this is when I would tell the patients to take it one step at a time. And at this point in time, no. Let's figure out everything else that's going on. Is it still a possibility or totally off the table for the future? That we can talk about later. But if she's got any thoughts about having that reverse anytime soon, the answer would be absolutely not.
So what would be your next step then?
I think that the question of, looking in the vagina again, making sure that there's nothing there. And then, we've seen far too many patients that, you have to assume whether this is UC or Crohn's, that she has some sort of IBD in her rectum, and that what you're seeing there now is not just diversion proctitis.
Yeah.
And her risk of malignant transformation in the future would still be high. And the last thing you want to do is just leave her rectum there because you don't want to get back in her abdomen and then have her, come back with a rectum that's, completely replaced by cancer. Then you're really in a bind. And so, I would probably talk to her about, at some point, we, likely need to remove your rectum just to prevent that. And so I think it would be more, whether that happens immediately or, in the near future, but talk to her realistically about that kind of being one of the next steps.
Okay. So, but let's say the clip works, she gets her hips fixed, she's ambulatory. Would anyone consider an ileorectal for her? Or would everyone go for a pouch?
Joey, was she ever on any therapy prior to her presentation? This is just
She had 1 month of symptoms, a CAT scan and a colonoscopy, was perforated, never had any antecedent symptoms prior to this.
Philosophically, I would be okay doing ileorectal anastomosis in indeterminate colitis patients if everything is okay. But I don't think this rectum's healthy. You know what I mean? So from my perspective, if she had proctitis on presentation, most likely, if you ever did reverse her, she'd need a pouch.
Okay.
In my opinion.
Which goes to the next question, if I can. Can I get a J pouch?
eventually.
Yeah. The things to consider, reoperative surgery, you're going to have issues with either J-pouch reach to the pelvis or the diversion ileostomy that, especially in this patient, I would really like to be able to make, may also have reach issues once you make the pouch.
Yeah.
So yeah, I like Teresa's answer, the eternal optimist, and Sean's, theoretically, absolutely, but in practicality, it's a stretch. It's a possibility, but a stretch.
So everyone's first step would be to locally revise the ileostomy for comfort and potentially try to minimally deal with the rectal stump fistula, maybe endoscopically as a first step.
I have to admit, I still don't know why she's having so many symptoms, ongoing symptoms from a rectal stump fistula. People have these and they're essentially asymptomatic, or they have a Band-Aid over them. And so
she's not. I mean, she's eating. She's not having a lot of symptoms, but she's kind of in a holding pattern because the orthopedic surgeons don't want to fix her hips. She can't walk. She is wheelchair bound, but she is kind of like, somebody's got to do something.
Well, if ortho gets to dictate the order of things, then yes, I would start with whether we're locally revising the ostomy and trying to do something small to try to help the fistula debride, the tract and decrease the septic focus for her.
Yeah. So we have one hip, we have one hip guy here. And so it's like, we could send him somewhere else, but there's not, like, where we are, there's not that many other hip folks. Like,
Yeah.
the other hip folks are about 2 hours away. And obviously she, with insurance issues and other stuff, like, this is her shot. And we have good people in our institution. So this was the negotiation, was the, do you bite the bullet and do the hip and then deal with the thing, or deal with the gut, or do you deal with the gut first? So it sounds like for everyone, if things clear up, or she's able to get her hips and she's able to be more mobile, that a J pouch is a reasonable option for her. And then, so she thinks, she asks another question. The last question she asks is, can I just have my rectal stump fistula fixed, then have my hip replacements, then figure out my bowels later? That would require an XLAP, restapling off the stump, and then revising the ileostomy, and then coming back later to do the J pouch.
Why not MIS?
That's a great question. That was going to be my next question. Would anyone consider taking a look MIS?
Absolutely. It's been a year.
Okay. Well, how would you talk about how you would gain entry? How do you gain entry in these cases where you have an open abdomen for several, about a week and a half, and then you're coming back a year later? How long do you wait? And then how do you approach that MIS?
I think the year is probably what I would have told the person before I would even talk to them about it again. So I think that that's appropriate. If we're in the operating room, I usually do an open Hassan, a cut down for these cases, and I try to go high and lateral in the left upper quadrant, kind of Palmer's point type of thing. And then you see what you can try to see.
Would anyone else consider MIS for her? Year later, open abdomen for 10 days. Pat?
We always recommend, starting MIS. You can always convert, but I would absolutely do it. I don't do Hassan. I go in the left upper quadrant, which is my safest zone, and I do a optical view entry into the air. And then you within 10-15 minutes, you'll get a feel to whether or not it's even feasible or not. And then you go slow. You go real slow. No heat, sharp only.
Yeah, this is the case where you have only her on for the day.
One day, yep.
Love it.
And not on call.
And not on call, right.
Yeah. If you're revising the ostomy, that's where I usually go in on these types of cases, because there's an ostomy usually involved, is I'll take down the ostomy first. I know some people like to start laparoscopically and feel like taking down the ostomy is easier that way, but usually you can get, a SILS or one of the other hand assist ports at the ostomy site. And, but if we're not revising the ileostomy, which you could get in a big mess trying to revise this ostomy, I would try, but I would probably have a pretty low threshold to convert if it's just a hot mess in there.
So Lisa, you would consider just dealing with the rectal stump, not dealing with the ostomy at all? Say, you're having ostomy issues, we'll deal with that later. Let's just deal with the stump issue so you can get your hips taken care of.
I mean, unless her skin is literally like sloughing off because of the ostomy appliance, issues. I think there's a lot that can be done with ostomies with enterostomal therapists that are underutilized.
Somebody mentioned dealing with the stump endoscopically. I think is a great approach. I would absolutely utilize that to try to see if you can do something completely endoscopically before you commit to something more aggressive.
All right, good to know. We'll see what happens. I'll let you know.
Good luck, man.
I thought you were going to tell us that you went straight and did a pouch.
The question that I have is that you're going to do a pouch, and then she also has these chronic, I know they're isolated to the hip joints, but that's within that area. And then what happens if you have a pouch leak? What if you have, now a pelvic, you have pelvic sepsis and bilateral hip sepsis? I mean, I think you're already dealing with problems. I would not do a pouch now.
Right. Well, I mean, these cases are easier when the patient is. Sorry, I don't know what that was. If the patient was much older, or if it wasn't, a walking, talking, normal 44-year-old at the start. But clearly, we really want to try to help this woman. But
Right.
There's a lot of room to try to optimize her and take more time with it, you know. And it's also important for her to tell us, you know, how desperately she feels that she wants to live without an ostomy, because if she were to succumb to or agree to, if I just had a nice ostomy that I could change the bag once or twice a week, it totally changes the game for what our stress level is over how we work her up.
Yeah.
You know, and I'm sure you've had those conversations with her.
Yeah. And let's say, and actually she's gotten to that point where I just want to have one operation where I have a one good ostomy and I don't want to deal with this anymore.
Yeah.
Would you consider doing a completion proctocolectomy, giving her the give her a nice endoleostomy and then be done?
Yes.
Great case, Joga. All right,
Okay.
and then I just need you to stop sharing your screen.
We'll unshare. One sec. Let me get that Zoom going.
One more case to share. Thanks everybody for your attention.
Sorry.
Joining in. Good to see you guys.
There we go. Stop share. Perfect.
All right. Let's see if this will work. All right. Are you guys seeing that in full PowerPoint mode, or does it look like my desktop with PowerPoint?
Full.
Full. All right. Well, excellent. So thanks, Joga. Thanks, everybody, for coming. Let's continue with some nightmarish, freaky cases to discuss and lend your intellect and expertise. Let's see. Now, the only thing is, let me get out of that mode. All right. So we've got a 58-year-old male that you're seeing in the office with the billing diagnosis of ulcerative colitis. He's had ulcerative colitis for about 15 years, probably now only been on medical therapy for the last 10 or so. But as a kid, he kind of was the kind of kid that had an upset stomach all the time, he reports, but really it wasn't until adulthood that he was diagnosed with this. He's always predominantly had left-sided colitis on endoscopy, active, but he's had some random biopsies that showed chronic colitis as well. So he, his most recent surveillance colonoscopy showed some high-grade dysplasia and an intramucosal adenocarcinoma in the rectum, mid-rectum, and this was confirmed by a second GI pathologist. So these are his photos from his last screening colonoscopy and the random biopsies where they demonstrated chronic inflammation but inactive was present in the ascending, transverse, and proximal descending colon, and active inflammation, the descending colon, sigmoid, and rectum. And this rectal mass biopsy was a targeted biopsy. It was not a blind or incidental biopsy. You can see that there's the mass there. So what's your diagnosis and what additional workup do you want, if any?
I'm happy to start again. I think we all kind of agree on this, I would assume. So this is a discrete lesion you can see. It's in the setting of active proctitis. I would probably MRI the patient's pelvis, make sure that that's as deep as it goes. I'd look at it myself in the office to find out where it is in the rectum. And, you know, I think I don't have a problem with doing a local excision of a discrete lesion in this situation, probably with TAMIS, realistically. But the bigger issue is the patient's got ongoing inflammation. And this is more of a field defect. So if you stop there, you'll be taking another one out soon or something worse. And so for me, the bigger issue is trying to achieve endoscopic remission. Didn't look like it was on a biologic. And so I'd have to talk to the GI doctor and get more information. Now, if they were failing therapy or they had intractable symptoms, then that's a patient that gets a proctocolectomy and pouch. But
Yeah,
for me, I have no problem.
Yeah, no biologic therapy, never been on biologic therapy because as far as he's concerned, he doesn't have any symptoms on medication.
Sure.
Did they do chromoendoscopy at the same setting or?
They did, and no other obvious lesions. So the rest of the biopsies were, they were all random. This was the only visible lesion.
And he wants to keep his colon.
He wants to keep as much colon as you'll let him. Yes, that's correct.
I agree with Sean.
All right, MRI, any other takers? Anybody else want anything?
I would get a CEA and a CT also, just pretend it is cancer.
Yep.
Yeah.
All right.
And Lisa, his small bowel is normal?
Yeah, so we got an MRE. Yep. So the good call on that. MRE was normal. EGD was normal. Up to, a couple of centimeters past the duodenum. CEA is normal. CT chest, abdomen, pelvis was negative for metastatic disease. The MRI, however, was really difficult to read in this area. And I'll show you guys the video as well, so we can kind of scroll back and forth or have that element of it. But the MRI, especially in this little turn here, right before it comes thick, and the mass is about mid-rectum, so right about where this thickening is here. They described this possible 2-centimeter tumor. It's hard to tell inflammation versus infiltration, and they labeled it as a TXN0. And then there's a little bit more, just a still image, so you can kind of see. That's what most of the mesorectum looks like. So I'll show you the video real quick here. Sorry, this is me hand holding my iPhone, scrolling down. But you can see really thick mesorectum, definitely an IBD mesorectum. No fistulas, no problems with the sphincter area or the ischiorectal fossa. But about right at this turn is where the mass is seen endoscopically, as well as it gets a little hazy in that T2, T3 region area. But the mesorectum, we studied this for hours probably before his operation, and we couldn't find any notes that were suspicious. All right, so what should we do next? Or actually, let me give you the CT scan, just so you can, if you're thinking about saving any of his colon, we'll just travel up the colon here. First, we're gonna go down to the rectum, see if the CT scan shows us anything. Nope, ischiorectal fat's still clean. We're gonna just travel up the rectum so you can kind of follow the colon as it goes up, makes that nice sigmoid turn. So it's like, maybe if he truly does just have left-sided colitis, we might be able to do an LAR here. Depends on how much inflammation, the extent goes up to the descending colon. But you can see he's actually got some colon to work with. And that's just taking it all the way around to the cecum, just in case you get in trouble and you have to do some crazy bailout right colon maneuvers. All right, so what do you guys think? What do we have so far? What are our management options?
I mean, I would be anxious to have the endoscopist go back and do a proper, a repeat colonoscopy, but really doing mapping of the rectum to really understand whether or not this is an isolated or this other focus of low-grade dysplasia in the rectum, especially. And then the other thing is we still don't have any evidence that it's a cancer. So, I mean, I agree with Sean. I mean, I think doing an excision, if they can't take this out endoscopically, at least doing a full thickness excision to confirm this is not an actual cancer. And that you can actually, it's associated with a lesion, well-defined lesion. So potentially you could resect it and observe him.
Oh, that's a good point. We didn't do that, but let's say it comes back the exact same. All the mapping's negative. They still have this targeted lesion that still has intramucosal carcinoma.
I mean, intramucosal carcinoma is high-grade dysplasia. This is not an invasive cancer. So, you have to have a discussion about the patient about, the field effect is one thing, but he hasn't really been given a chance to cool off his rectum. I agree with Sean with that. So, I mean, potentially you could completely ablate the lesion by removing it, stage him properly, confirm it's not an invasive cancer, and then offer him observation and biologic treatment with close surveillance intervals at 3 to 4 months.
Yep.
It would not be unreasonable before, pulling the trigger.
And how about the MRI? The radiologist wouldn't call it T-stage. What are you going to call that? You think that's inflammation that we saw, or do you think that may be but
that's the reason. That's the reason you want to excise it. You want to know whether or not there's a cancer. There's no better definitive diagnosis than doing a biopsy. I mean, a full excision of the area and confirm your margins are negative and there's absolutely nothing left behind.
Okay.
Agreed.
So it is a cancer. It's
nice.
at least a T3 cancer. So now what are you going to do?
So,
You
okay, I'm speaking again, but so now you have somebody. So I would get in before we know it's T3 cancer. When I can't tell, I don't trust the MRI. I like to split the difference endorectal ultrasound, and I would very reasonably do an excisional biopsy if I didn't believe that it was a cancer. But if I know that it's a T3 cancer, there's no suspicious lymphadenopathy, I'm not too hot on doing radiation on somebody and then doing a pouch. And so, I mean, I'd presented my multidisciplinary tumor board just to be political. I'm curious what other people would do. I mean, for me, I might go straight to an operation so I can do a restorative procedure in this patient.
I had the exact same case where he came back as a T3, and actually we ended up doing, we were worried that we couldn't really definitely rule out nodes. And so the worst thing you want to do, Sean, is to do a pouch, and then you end up with positive nodes in your specimen. And then you end up having to radiate, you know, and so this is a real problem because you cannot radiate a pouch. So in that particular patient, Lisa, we actually did I did a subtotal colectomy with low anterior resection, left a 6 centimeter long. I was able to get below it at about 5 centimeters, so left a very short rectal stump. And then we just came back with Sergey, my partner, who's a specialist in mucosectomy, and we ended up doing a pouch with mucosectomy. He's a 47-year-old male. We're lucky he had no positive nodes on his final path, but we wanted to make sure we didn't have to deal with a positive node and having to radiate him post-pouch. So we elected to do it in 3 stages, essentially.
Yep. So it sounds like from the group, we'd prefer to have some sort of confirmation with either TEM, TAMIS, full thickness resection, get an accurate T stage as best we can before any more invasive. Very good. All right.
But if it's a T3, Lisa, we tend to do some short course radiation here, and I think this would be a good indication for the exact reason that Pat was talking about, that if you ended up having positive nodes, that you've already given them neoadjuvant therapy.
Yeah, no, I think that's a great option. It's just he's got ulcerative colitis, and our radiation oncologists are pretty aggressive, but they are really timid when it comes to radiating IBD.
Really?
The problem also with these tumors in patients like him, as small and innocuous as this thing looks, I mean, they tend to behave really poorly comparatively to patients who don't have IBD. So I probably would be more aggressive to give neoadjuvant therapy for this guy. I wouldn't say that I'm not concerned about doing it, but I wouldn't say that that would be a contraindication for me doing a pouch on him afterwards.
Right.
You know.
Yeah, my patient, we ended up giving him chemo, and he actually refused radiation, which was recommended, but he didn't have any positive nodes. It was more because of the T3. But he declined radiation, which at MGT we felt was not unreasonable. But yeah, if you can do, I like the idea of short course in those patients. It's not a bad idea.
So just to play devil's advocate here, I mean, do these patients truly need radiation if you have a mesorectal specimen that's intact? And so I bring it up because I think you have to let the patient decide. And I am very lucky. I have great oncologists here, great radiation oncologists. They're reasonable. And if they see the intact mesorectum and the negative nodes, they're not going to somehow kidnap the patient and radiate her pelvis or his pelvis.
Right.
But you guys are right, because not every environment is that way. And I have talked to several people who are very aggressive with short course, because they know if one of those nodes comes back positive or comes back T3, that patient's getting whatever pelvic anastomosis they have is going to get radiated. And so I think it's a great idea, depending on your
and ours, with a complete TME with a very large CRM, ours can be talked out of doing radiation for 1 node, maybe 2, but when you're starting to have 3, 4 nodes that are positive, and you don't know that until you get the specimen. So that's the concern. I think I'd much rather err on the side of radiating something that's coming out rather than, you can't radiate a pouch, then it's not going to function right.
All right, so everybody gets what they want before surgery. What are you doing, LAR or total proctocolectomy and pouch?
I'm going to do a pouch. I'm going to do total proctocolectomy and pouch.
Anybody else? There's a nice long colon there. It's only really ever been active left-sided.
There's no
This
data.
guy gets one chance. This is his one chance.
What if the nodes are positive? then you're gonna have to radiate a pouch unless, you know, the other things are.
This is not his one chance. I'm telling you what I just did, my guy. You can do an LAR, you know, and you achieve a negative margin, Lisa, right?
Yep.
And you examine the specimen, you get all the information, you decide if they need radiation, and then you come back and do a pouch. And it's not impossible, especially now with TAMIS. You know, if you're not comfortable doing a mucosectomy, and you're having a difficult time digging the stump out, we have the beautiful option of doing it with TATME approach. You can dig out that rectal stump from the transitional approach and then still do your pouch. There's really no reason you can't technically do it with all the tools we have now.
And truly, he's probably got enough length below that for you to be able to get it.
Yep.
And then you know, check the total status before you go.
If this guy has a segmental colectomy, is this patient going to be following with all of the necessary scans, MRIs, colonoscopies, surveillance? Is he going to do all that? You know, he seems to be kind of negotiating his care anyway, minimizing his symptoms. You know, I think that probably in the long run for him, the safest option and still definitive for his cancer is a total proctocolectomy.
Gotcha. All right. So for this gentleman, we did an LAR and no treatment because the MRI looked so impressively outstanding. So he does well, goes home on post-op day 3, divergent ileostomy is great, not even any high output ileostomy. And then his path comes back.
Well, there's 3 positive notes.
Yep. So,
The original.
I'll stop that. So he's got some signet ring cell carcinoma. This is just like literally just keep scrolling down the page and it's bad news every single line. Lymphovascular invasion, perineural invasion, tumor budding. You know, the guy's path wrote the book on all the things you never want to see. And then interestingly enough, his circumferential radial margin is 1 millimeter.
Oh.
Even though he had that nice big beefy mesorectum. So this mass, that was not inflammation on the MRI. That was tumor, and it was on the thinnest part of the mesorectum, unfortunately. Distal proximal margins are fine. The TME grade was complete. So what now?
Adjuvant.
Gotcha. Everything, radiation, chemotherapy. Everybody agree with that?
Yeah, I mean, you have a threatened margin, and you're worried about local recurrence.
Yeah, and it's a nasty. This thing's as nasty as they come.
I think the biology is going to dictate what's going to happen to this guy, unfortunately.
Yeah.
So well, let's skip ahead. So he undergoes 6 cycles. A modified full Fox does actually pretty well. Thereafter, he gets radiation with concurrent radiosensitizing chemotherapy, tolerates that well as well. I mean, he's got the diverting ileostomy. So now what? Almost the same question. Do I get my ileostomy reversed or do I do more surgery and get a J pouch?
What does he want?
He's really freaked out that he had a stage 3 cancer when we didn't even think it was going to be an actual cancer. So he's not really trusting the rest of his colon anymore.
Then it comes out.
This guy's got horrible biology for a tumor he already has. We've already committed him to a low anterior resection.
Yeah.
It would be hard pressed to go back and just prophylactically remove the rest of his colon, then make a pouch and radiate field. I would not do that. For what it's worth, once we've kind of made the commitment that he's got this low anterior, he keeps the rest of his colon unless he gets severe symptoms from it. Is he having any symptoms from the proximal colon? Or?
No, and you know, I was kind of hopeful that the anastomosis would be stenotic and his rectum would be trashed, and it looked actually beautiful. I'm sorry, I didn't have the photo from that, but it literally, I'm teeter-tottering and literally letting the patient dictate this move because you could reverse the ileostomy in this patient if that's how you felt strongly.
And I feel like he bought the LAR, so he should drive it for a little while and see what it looks like.
Yeah, because going back and doing a total proctocolectomy is not going to change anything for survival in the next couple of years. So I think that that's very reasonable.
His fate is dictated by his rectal cancer, not really what happens to the colon at that point.
Right.
I agree.
Yeah.
That's what I was going to say too. I mean, it's better just to, if he doesn't want to live with the ileostomy, just, let him fly for a little bit and then see what happens with his cancer again.
Okay. Well, you guys are stronger than I am because I got talked into a total proctoclectomy J-pop.
Oh my God, so much courage.
And shockingly, it was the only case of the day. I will readily admit that, but it wasn't as bad. And he actually
How long did you wait?
Well. What's that?
How long did you wait?
I think it was a good 9 months following by the time he was done with chemo and radiation and everything, and still waited, for whatever reason, 10 to 12 weeks following radiation, just because that's what I do. So we're looking at his pouch, getting ready for the ileostomy reversal, and he's got this bridge in the middle of his pouch. How do you guys manage these things?
Biopsy it.
You guys know what I'm talking about? Like this thing's clear above and below this line. This isn't the apex of the owl eye. There's actually you could go around this thing with your scope, and it's literally just a fused bridge, almost mid, like the two sides of the staple line just fused together randomly in the middle of the pouch.
Staple across.
Well, I would biopsy it though too, because you've already given us all these weird curveballs. I just assume he's got some weird cancer. But, I agree. You can manage that endoscopically. But really, I've to be disclosure, I fix other people's pouches more than my own for this. But I've gone in there with a linear endo-GIA and just right across his.
Come across. Can you ever do it where you see it, or is it always kind of a blind insertion and fire the stapler and then look again and see if you actually got it?
I like to use flexible.
Very good.
Why can't you do it with TAMIS? You can put if you can fit the TAMIS platform, you can put the stapler through and do it under vision, no?
Yeah, they've usually, these are pretty easy. They're almost kind of like fingers reach, and I just have done it with like a little endoscope essentially.
Oh, okay.
I don't have like a huge case here. You guys would know about it if I did.
You can even just, as long as the anus closes, you can fit the stapler right through next to your endoscope and just do it that way too.
Are you doing this the same day that you reverse the ileostomy, or are you going to do this first and then make him wait?
Well, only because Sean said he wanted to biopsy it first. I guess I would wait.
All right.
But wait, aren't we in the office right now? Didn't you see this in the office?
We're in the office right now, yep.
Yeah, so I'd biopsy it.
Okay, I didn't biopsy it.
But yeah, if you were in the operating room closing the ileostomy and you were looking at this, I would just staple across it, wouldn't think twice.
Okay. I made him do the staple first and then wait a month and make sure it stayed open, and then we reversed his ostomy. So this is what it looks like kind of afterwards. Sorry, I didn't get a great photo, but yeah, you just literally staple this across and the two edges kind of just die. And this is not the first time it's happened. So I never really saw this in training, but I've seen it a few times now in practice. All right. So anything else? Reverses ileostomy? Be done finally with this case from hell?
So just the two edges of that bridge died, but the actual pouch underneath is
just
viable.
fine. Yeah.
Okay.
Yeah.
All right.
Exactly. All right. So 2 years later, the GI sends you this EGD.
Huh.
He's fine from a cancer standpoint, has the worst pathology I've ever seen, and is NED from his cancer standpoint. So there you go. IBD, always getting us in the end.
Yeah.
So he's actually doing pretty. He initially started with some pretty bad pouchitis-like symptoms, even though he really did fine in the first 6 months or so. And so his pouch always looked fine, but when he finally got the EGD, then we realized that we were dealing with Crohn's, not ulcerative colitis.
He's on biologics now.
Yep. All right, but thank you all for attending tonight, and for anybody who's watching and doing the remote Sages online learning. We hope that you enjoyed this, and we really thank you for all that you've been doing through these crazy pandemic unprecedented times. So keep up the great work. Any final words of wisdom from our awesome panel?
Thank you.
No, I mean,
Thank you.
Lisa, I would just say that the last thing is, I think what I've learned over time, especially with TATME, is that I'm much less nervous about doing, as I said, the proctocolectomy and LAR and go and get the cancer out and then kind of go back and not be worried about how am I going to put them back together. Because I was a fear when I was training and after, is how am I ever going to be able to get back in there and do a pouch, or how am I going to get back in there and do a, you know, a coloanal. And then you can, now that we have all these tools transanally, I think we can dig out those short rectal stumps and put people back together. So it's incredible how much things have evolved over the past 10 years.
I agree. We actually had the TATME on standby for him just in case it was a bit of a nightmare, but it actually was a very straightforward pelvic dissection, and there wasn't that really had infused or incorporated even despite the radiation and prior pelvic surgery. So
great case.
Yeah.
Amazing. Very
well
cool.
done.
Thanks, everyone.
Thanks, Lisa. Thanks, Hugo.
Thanks.
Thank you.
Take care, guys.